Welcome everyone. We're very pleased to be offering this webinar in partnership with ONTABA and Autism Ontario. We hope that you will leave with some useful strategies that you can apply to your own clinical practice and supervision of trainees. Welcome and thanks for joining us. I'm Kendra Thompson. I'm a BCBAD Associate Professor in Applied Disability Studies at Brock, clinician scientist at Azrieli Adult Neurodevelopmental Center, and currently the president of ONTABA. I am very pleased to introduce my co-presenter, colleague, and friend, Nancy Marchese. Nancy is a BCBA and psychologist, owner and founder of Breakthrough Autism, and president-elect of ONTABA. There are a lot of us on today, and we just want to apologize in advance if we can't get to all of your questions, but please note that Nancy and I will be answering questions in real time in the chat box throughout the presentation since this has been pre-recorded. So COVID-19 has undoubtedly impacted every corner of our society. This image shows the countries with COVID cases in blue and those countries that have not reported cases in yellow. The difference obviously is stark. The quick spread of the virus and steady increase in the number of reported cases has had a great impact on all of our daily functioning, including disruptions to personal routines and social activities globally. Temporary closures and pandemic-related changes to various businesses and organizations have impacted an array of behavioral services and supports for those who may be considered among the most vulnerable members of our society. The impacts of the pandemic have forced modifications to how behavioral services are offered. It's also changed how supervisees receive training. Innovations in technology in the last few decades have led to innovative and effective application of behavioral technology through telehealth. Behavior analysts can capitalize on the empirical basis for telehealth while continuing care for clients and also continuing high-quality supervision of trainees. I've heard of many great examples of local agencies who have innovated ways to leverage telehealth to continue to care for clients and their families during pandemic-related restrictions. Later, I'll present some potentially innovative examples for how to provide behavior analytic supervision and training opportunities under these restrictions, as well as transitioning back to less restricted services. At the start of the pandemic, there were understandably questions about telehealth in ABA and whether enough empirical support existed to offer it for clients. There is very convincing results in the literature in terms of remotely training others to conduct assessments. For example, in a study by Wacker and colleagues, they effectively trained 20 parents to conduct functional analysis procedures within a multi-element design. The results identified environmental variables that were maintaining problem behavior for 18 of the 20 cases. In my own practice, working clinically in early intervention, in Manitoba, I would often rely on parents to conduct functional analysis procedures as well. Although that was in person, this is good evidence that we can also reliably conduct these procedures remotely. There is also empirical support for training others to implement interventions. For example, Neely and colleagues trained interventionists to Fidelity to implement incidental teaching. Following the telehealth training program, coaches and interventionists reached a preset performance criteria and implemented incidental teaching with high fidelity. All of the child participants had corresponding increases in MANS above baseline levels. These are just two of the many examples of effective and efficient uses of telehealth for training mediators in implementing behavioral assessments and interventions. My former MA student, Joey Robertson, conducted a thorough review of the telehealth literature in 2018 in preparation for his telehealth training thesis. He summarized the following benefits from the literature. Telehealth reduces cost of service delivery. Lindgren and colleagues compared data on outcomes and costs for implementing evidence-based ABA procedures to reduce problem behavior by using 3 service delivery models: in-home therapy, clinic-based telehealth, and home-based telehealth. All 3 service delivery models demonstrated successful reduction of problem behavior through training parents to conduct functional analyses and functional communication training. Total costs for implementing treatment were lowest for home telehealth, not surprisingly, but both telehealth models were significantly less costly than in-home therapy. Telehealth can also eliminate barriers due to geography, which may be particularly important in this vast province and other more rural and remote areas in Canada. Surrey Place, for example, has a long-standing telehealth program in partnership with Northern Communities, and we know there are other agencies doing the same good work in Ontario and across Canada. The Barquet study examined the effects of intercontinental telehealth coaching on the mastery of therapist skills and improvements in verbalizations by children with ASD in developing countries in Eastern Europe. Experimenters provided coaching from Virginia, USA, to therapists who demonstrated improvements in 2 classes of behavior: correct command sequences and positive consequences. The children demonstrated corresponding improvements in echoics and MANs. The study demonstrated that telehealth can be a good model for delivering early intervention services to children with ASD in underserved and distant regions of the world. Telehealth has diverse applications. For example, a pilot study by Knowles and colleagues investigated the use of telehealth consultation models to increase selected teaching behaviors, for example, praise, prompting, and student opportunities to respond. They were also interested in looking at the impact of reducing challenging behaviors in a self-contained special ed classroom. Overall, the results suggested that increased targeted positive behaviors were demonstrated by the teacher and a substantial decrease of student challenging behavior upon the introduction of the first intervention phase. ABA telehealth interventions have also been used beyond ASD. For example, coaching parents of children with visual impairments, teaching parents to implement language and communication interventions, and teaching parents to implement interventions for their children with Prader-Willi syndrome. Telehealth can help us to build capacity for direct care professionals or other caregivers in various environments. Artman-Meeker et al. In 2017 examined the effects of a bug-in-ear device for coaching pre-service behavior analysts when they're implementing functional communication training with preschool children with ASD in the classroom. The bug-in-ear coaching was associated with increases in the rate of functional communication training, and each of the pre-service behavior analysts initiated this procedure with high fidelity. My student Joey also used bug-in-ear device for his evaluation, and we found it to be very effective in improving behavior analysts' use of errorless learning, as well as implementation of preference assessment procedures. The participants in the study also reported that they found the bug-in-ear device to be very useful. The telehealth research has also reported good social validity data in that users report it to be as preferred as traditional formats. For example, Sump and colleagues study included 2 skills trained via telehealth and 2 skills trained in person using BST procedures. The undergraduate student participants who were learning DTT skills provided high acceptability ratings for both training procedures. We had the same results in Joey's study as well. With anything, there are important considerations for applying telehealth in clinical practice or when providing supervision remotely. Neely and colleagues synthesized fidelity features in telepractice studies focused on parent, educator, and therapist-directed treatments for individuals with ASD. Their search identified 19 studies that met inclusion. The results indicated a variety of assessments and interventions for targeting and coaching with a variety of procedures used. Implementation fidelity of the training procedures was also not well reported, suggesting that future research with well-reported implementation fidelity is needed. 2 things that we found when we were synthesizing the telehealth literature for Joey's thesis were, not unlike other areas of study in ABA, generalization and maintenance measures were also underreported. Interestingly, training was often reported as fixed duration versus competency-based, despite what we know about evidence-based training being competency-based. Lerman et al. Reported in 2020, although remote training offers a number of advantages, it brings a variety of challenges that are unique to the modality. Their paper reports on the experiences of 18 practitioners who provided caregiver training via problems and include case descriptions and data to illustrate the experiences that could be generalized to providing remote supervision. Most frequently reported, not surprisingly, were technical issues. There are some other considerations for remote supervision that we should also consider. One being the supervisee and client access to technology. For example, if you're providing supervision to a trainee working with a client that does not have access to adequate technology, this may be a potential barrier and something to troubleshoot. Also, supervisee and client preferences. Similarly to access to technology, if the clients or their caregivers do not prefer technologically mediated interventions, then we can also have to consider this when we are supervising our trainees. Training and troubleshooting. Depending on the supports in the environment, a potential supervision activity could be supporting a supervisee in how to train clients or caregivers how to use various technology platforms and also provide strategies for troubleshooting the use of those. We need to also pay very close attention to the various guidelines that are provided through our various associations and public health regulations. All of the major associations in our field have put out information, including practice guidelines and telehealth resources that we should continuously refer to. We can also generalize from what we know from the literature. Some guidelines already exist for troubleshooting, as I mentioned, one by Lerman and colleagues, but Lee also published guidelines for telehealth with caregivers, and Rios et al. Have published remote supervision guidelines, which would be particularly relevant. So this recently published paper was the inspiration for a paper that I recently submitted with two colleagues of mine, Priscilla Burnham-Riosa and Albert Malkin. The purpose of our paper was to expand upon Fronpol's and Demchak's 50 suggestions for BACB supervisees working in school settings to accrue independent fieldwork experience hours during the pandemic. We aim to provide cross-sector suggestions on how BACB supervisors may leverage supervisee support using innovative practices to develop their skills as budding clinicians, assist supervisors with critical tasks, and ultimately support clients during a time of unprecedented disruption. The examples of trainee activities and the corresponding task list 4 and 5 items were developed to act as a springboard to action for supervisors and supervisees. I will share 3 examples from each task list, which are based on our collective experience, knowledge, and review of the literature. Please note that the paper is still under review. And in other words, the suggestions are not meant to be comprehensive, but to provide guidance. We endeavored to include conceptually sound ideas, though are not claiming each has an extensive evidence base. In fact, where instances in which the evidence is emerging, it might highlight opportunities for researchers to add to the literature. In the paper, we set up 2 tables, one for task list 4 and one for task list 5, with some ideas for supervision activities that correspond to the task list items and the available literature to support it. This is one of the examples under behavior change systems, F7, use functional communication training. We suggest that supervisees could develop and implement protocols to virtually train mediators, parents, direct support professionals, etc., in how to conduct functional communication training. We also include 2 supporting articles for this task. This example is for measurement, specifically H1. Select a measurement system to obtain representative data given the dimensions of the behavior and the logistics of observing and recording. We suggest that supervisors can train supervisees and mediators to collect data using behavior tracking apps on smartphones on a doable and realistic schedule. The Tarbucks et al. Study shown here demonstrated that electronic data collection was approximately equal in accuracy to pen and paper, but that traditional data collection is faster. This is an important consideration when setting up recording schedules and training supervisees and mediators to use this modality. From personnel supervision and management, I2, establish clear performance expectations for the supervisor and supervisee. Our suggestion is that supervisors can train supervisees to self-monitor their own compassionate care and therapeutic relation skills when they're conducting sessions via telehealth. They may do so by filming and reviewing sessions with their supervisor and taking self-monitoring data in order to share their self-assessment. Nancy is going to speak more about compassionate care later on, so I won't steal her thunder. But understandably, supervisees and supervisors have to pay careful attention to therapeutic rapport when we're delivering services remotely. Having clear expectations for performance within remote supervision or clinical conditions is imperative. For example, agreeing that both parties or both ends will turn off email and text notifications to avoid distraction. This example is from task list 5, which importantly includes a section on ethics and relates to the following items in that category: E2, behavior analyst's responsibility to clients; E3, assessing behavior; and E4, behavior analysts in the behavior change program. Our suggested example is that supervisors can provide training to supervisees in how to create decision trees related to carrying out specific interventions during the pandemic, and then consider whether specific practices lend themselves well to telehealth. We know that telehealth is not appropriate for all clients, but has been working very well for some. There's also been some lively discussion in the literature surrounding the ethics of this rapidly evolving situation. For example, Cox et al. Published a decision tree for risk mitigation very early on in the pandemic. The preprint was released on March 28th. The paper was met with some criticism from other authors in the field, namely responses from Colombo et al. And LeBlanc et al., who critiqued the model and went as far as stating that the paper was suggesting an abandonment of clients, which from my reading it was not, but I'll leave it up to you to read and come to your own conclusions. We argue that this is an incredibly important time for supervisors to revisit their understanding and adherence to the BACB Professional and Ethical Compliance Code and other guidelines that have been put forth by agencies regarding ethical remote practice. For example, the practice guidelines from APBA, telehealth resources from ABAI, etc. The next example is from behavior change procedures, specifically G5, use modeling and imitation training. We suggested that a rich supervisory experience would be creating video prompts for clients' daily living and social skills during pandemic restrictions. For example, teaching how to wear a mask, teaching how to connect socially or to access technology. There's ample research to suggest the use of video prompting and video modeling, and these are just 2 examples. The last example that I will share is from H, selecting and implementing interventions, specifically item H3, recommend interventions, goals, and strategies based on such factors as client preferences, the supporting environment, risks, constraints, and social validity. We suggest that a good way to train supervisees on the importance of social validity would be to involve them in developing social validity measures to specifically evaluate telehealth applications. It's also a very important time to consider client preferences, as it is always, but specifically client preferences around use of technology. So I'll leave you with just a few parting thoughts before we switch over to Nancy's part of this presentation. The purpose of what I presented here today, largely based on the paper I mentioned that I worked on with colleagues, is really to be a call to action for supervisors to continue to provide ethically responsible clinical support to clients, while at the same time leveraging support from supervisees to further enhance the services that we're providing, and in doing so, providing trainees with a unique and enriching opportunity to continue to gain experience in the field. Ultimately, the pandemic can be seen as an opportunity for us to expand our own supervisory skills and continue to develop the competencies of our future BCBAs and trainees, who will undoubtedly be very resilient. Thank you.
All right. Well, thanks, Kendra. That was awesome. Great information for all of us. And I'm going to piggyback on Kendra's thoughts and talk specifically about how we can better engage parents within treatment planning, and also specifically within parent training. So what do we know about parental involvement, and specifically autism treatment? Although I do believe I'm going to be presenting research within this area, but certainly some of this can likely be expanded to other populations that we work with, such as developmental disabilities and others as well. So we know many studies have demonstrated the importance of parental involvement as really an integral part of applied behavior analytic interventions, especially with children with autism. Also, we know that practitioners often suggest themselves that parental involvement may enhance child outcomes. And so practitioners have reported things like greater skill acquisition, maintenance, generalization when it comes to skills, and also maintenance and generalization when it comes to reduction in challenging behaviors when parents are actively involved. Now, parents may participate in ABA interventions in a variety of different ways, but these include, but are certainly not limited to, participating in goal setting and treatment planning, implementing behavioral strategies, attending workshops and training about ABA. And when we look at the research, what we see is that much of the research is really related to parental involvement that focuses on treatment integrity. So that is the extent to which the procedure is implemented as outlined. We also see research when it comes to parent knowledge of ABA procedures, and that is training parents to mastery and maintenance in terms of implementation of the procedures and conceptual background. All very important things. So for example, parents have been trained successfully to implement techniques and strategies such as discrete trial training, naturalistic teaching, functional communication training, behavior reduction strategies, functional analyses, all at very high levels of fidelity, and that's certainly very significant and important literature. However, when we look at procedural integrity and conceptual knowledge, what we know is that training parents to a very high level of procedural integrity and solid parent conceptual knowledge of ABA does not guarantee the implementation of these strategies outside of the controlled training environment. So why is that the case? Well, when we look at that there are a number of different variables that we need to consider. So we know it's been very well established that treatment integrity and conceptual knowledge are certainly important elements to consider when it comes to developing parent training plans. And there is a strong and growing body of literature related to parent training that really focuses on child-specific factors, child skill deficits, problem behavior exhibited by the child, and these have been used to really guide and develop and support the implementation of treatment plans. But when we look at the flip side, so environmental variables outside of the specific training context, it's certainly been suggested, and if you speak with practitioners, I'm sure many of you out there would agree, that there are variables outside of the specific training context that most certainly influence parental adherence, engagement to ABA interventions. And when we look at the research, what we found is that it's been an area that's largely understudied. So what could be these variables outside of the training setting that may influence the likelihood of whether or not parents would engage and adhere to suggestions that we've made? So one example may be commentary from relatives or others within the community. So a parent may prematurely stop implementing an ABA procedure if they experience aversive social commentary from family or friends. And in fact, friends and family members may even offer suggestions that, if implemented, could directly contraindicate an ABA intervention. So let's say we have a child who's exhibiting challenging behavior that is maintained by attention, and we have a well-intentioned grandparent that advises the parent to tell their child when they engage in problem behavior to tell them that hitting isn't nice. Well, if the parent follows that advice, that would be contraindicative in terms of the likelihood that challenging behavior would be reduced. So certainly can be problematic when it comes to their child's successful outcomes within a treatment. Another piece may be the aversiveness of the challenging behavior itself. So for example, Stucco and Thompson in 2015 suggested that there are various ways in which child behavior can influence parent behavior. So for example, if a parent experiences their child's tantrum as an aversive stimulus, then the parent may engage in behaviors to avoid or escape the tantrum. So child engages in tantruming, parent may offer a treat or speak to the child, and if the tantruming momentarily ceases, this could result in two unappealing outcomes. One is that it strengthens the parent's avoidant or escape behavior, and a second is that it strengthens the future probability of tantruming. That is, if the parent's behavior, such as offering a treat or talking to the child, acts as a reinforcer for the tantrum. Also, the child themselves may deliver consequences that positively reinforce problematic parent behavior. So for example, a parent may advocate for their child to get an extension on a school project when the child falsely informs the parent that she is sick. And then the child is awarded an extension on her project as a result, and the child gives the parent a lot of attention, therefore positively reinforcing the parent's advocacy based on untruthful behavior. So these are all certainly areas that can influence, again, whether or not a parent, may follow some of our recommendations. And finally, and I know this is maybe a little uneasy for us, but we're going to talk about attitudes and beliefs, because those two can be conceptualized behavior analytically. And there is research that suggests that parent attitudes and beliefs can also influence the likelihood of implementation of behavioral strategies outside of the training environment. So Duran in 2001 in a conceptual paper suggested that parental optimism and pessimism, so the degree to which they're confident in their ability to influence their child's behavior, may be one factor that influences the likelihood of persistent problem behavior later on in life. And this is even in spite of if there is successful treatment for problem behavior in early childhood. So there may be successful treatment for problem behavior in early childhood, but if the parent does not feel confidence in their ability to influence challenging behavior, then it may persist later on in life. And so when we look at research that sort of explores this notion of the influence of parent attitudes and beliefs, we find that there are a few studies that explore this from a behavior analytic paradigm. So Duran and colleagues in 2012 explored this hypothesis, this notion of whether or not parental pessimism or optimism could in fact influence the outcomes of children who exhibited severe challenging behavior who were diagnosed with a variety of developmental disabilities. And in this particular study, parents were randomly assigned to one of the two following intervention groups. They had one group in which parents experienced a positive behavior support treatment package alone. And then they had another group of parents that experienced this PBS treatment package, but it was also coupled with what they called optimism training. And what this really involved were components of cognitive behavior therapy for the family that supported really shifting their attitudes and beliefs away from a more pessimistic attitude to a more optimistic attitude when it came to their confidence in their ability to influence their children's problem behavior. And what they found was that there were greater decreases in child problem behavior in the group that received PBS with optimism training in comparison to the group that received the PBS treatment package alone. And there were no major differences in terms of attrition rates of those groups. So both groups had parents who equally participated. And so based on these results, Duran and colleagues suggested that intervening on parental attitude in addition to child-specific behaviors may positively influence child outcomes. And so it's certainly something that is super important for us to consider. In some other studies that were conducted here in Ontario, Salish and Perry in 2008 and Salish and colleagues in 2015 described the development of the Parent Involvement Questionnaire. And really, these studies were conducted in order to develop a measure of parental involvement that was meaningful and statistically valid. And they looked at a variety of different types of parental involvement, including, but not limited to, things like involvement with the treatment provider, so how the parents communicated with the treatment team, did they attend meetings, did they implement strategies, and also the direct implementation of the behavioral strategies themselves. So of particular note and of relevance to this talk on supervision, Salish and Perry in 2008 defined self-efficacy as the parent's confidence in delivering the techniques of IBI and also their confidence in their ability to make a difference in their children's outcome. So very similar to the notion that Duran and colleagues also explored. So specifically, parent efficacy was measured by how difficult parents felt it was to engage in training, their confidence and beliefs about the effectiveness of their involvement, and whether they felt that their involvement actually influenced their child's outcome. So for example, parents were asked questions like, how difficult do you find it to be involved in training activities about autism and IBI? Another question was, how much do you feel your involvement in training activities about autism and IBI makes a difference in your child's progress? And so there were a variety of results reported through these studies, and one of the key results of Salish and Perry in 2008 involved a regression analysis, which revealed that really only self-efficacy, so that confidence in the parent's ability to make changes in their children's lives, the self-efficacy was really the only factor that predicted parent involvement. And of note, this finding was very consistent across a variety of child characteristics, so children's age and autism severity level. So again, this notion of parents' attitudes and beliefs can certainly impact parent involvement and potentially adherence to strategies that we suggest. So what does this all mean when it comes to the practicality of what we do every day? Well, there's this notion that is emerging across a number of different healthcare professions and has begun to be talked about within behavior analysis, and that is this idea of practitioners demonstrating compassionate care skills. And so the extent to which families have developed rapport with behavior analysts could certainly be a variable that influences caregiver input and also participation within our treatment plans. And research conducted across other healthcare professions, so within the medical profession with physicians and also nurses, suggests that patients highly value strong rapport with their practitioners, and that the nature of these professional relationships can directly impact the effectiveness of the treatment. So specifically, professional behaviors that have been characterized as empathetic and compassionate have been associated with notions like, or outcomes like, improved access to qualitative assessment data, better patient outcomes, reduced risk of professional litigation, improved patient adherence to medical protocols, and many other benefits within the field of healthcare. And so if we look at how this may extend to the field of behavior analysis, it's been suggested through conceptual papers that when compassionate care skills are demonstrated by practitioners, this certainly may allow for opportunities for us to listen and gather information related to meaningful parent goals and outcomes. And thus, compassionate care may facilitate collaboration and also the development of therapeutic rapport between the parent and the practitioner. And yet, in spite of this importance of acquiring compassionate care skills, behavior analysts are not routinely trained in this area. And certainly the literature is beginning to suggest that there's a value in changing our training to address these pieces. So when we talk about compassionate care, what are we actually talking about? Well, the literature across a number of different healthcare professions, again, examples include physicians and nurses. So the literature across a number of different healthcare professions strongly suggests that compassionate care skills can be operationally defined and taught. Let's talk about those specific skills that may be considered to be compassionate from the client or patient perspective. So for example, nonverbal and verbal behaviors associated with collecting information. So things like asking open-ended questions and summarizing what has been heard would be ways to operationally define what is considered to be compassionate care. Also, active listening, so maintaining appropriate levels of eye contact with those that we are interacting with and having conversations with, nodding, and making some minimal expressions in response to some of their responses. So things like, closing that computer, right? And really engaging with the families while they are responding. Remaining silent while the parent responds. This is a really tricky one for us as behavior analysts because what we really want to do is dive right into the solutions. So it's a good skill to practice is just to be there in the moment, silent and listening. Also picking up on suggestions. So using phrases like, let me see if I have this right. It sounds like, and reflecting back some of the content that you've heard. I'm stating perceptions of parents' feelings, so I can imagine that must be ... it sounds like you're having challenges with, etc. Requesting and accepting correction, so asking questions like, did I, miss anything? And finally, offering support and partnership. So making statements like, I'm really committed to working with you and your child to support successful outcomes. And here, while we've operationally defined these pieces, what's really key to keep in mind is that authenticity is super important. You really want to deliver this in a truly, meaningful way from the heart in order for families to be engaged with you and to develop that important collaborative relationship. Okay. When it comes to social validity in parent participation, we must also consider the degree to which goals, procedures, and outcomes are meaningful and acceptable to parents. And Kendra already touched on this as well, the importance of social validity. And we know that this is really considered to be one of the most critical pillars of ABA. So social validity tools can certainly include subjective measures such as questionnaires or normative comparisons. And really it is likely that the degree to which the family finds goals, procedures, and outcomes acceptable and meaningful, that this will influence the extension of treatment effects beyond the controlled clinical settings. That is to say, the more the families endorse the goals, procedures, and outcomes, the more likely they're going to use all those hard-worked, evidence-based strategies that you've worked on together in everyday life. Therefore, it is important for clinicians to consider the relationship between social validity and parental adherence when it comes to treatment plans. So, for example, in the development of parent training plans, think about how meaningful are the treatment goals, the outcomes based on the parent's perspective. Ask them. Ask the parents, are they comfortable with the training procedures that you're proposing? And, talk about different environmental variables that may influence the acceptability of the target selection, the training procedures, and outcomes. What do we mean by that? Talk about what's going on in the family's life and use that information to help drive the treatment plan. Importantly, if the parent-practitioner collaboration related to these factors is considered during the development and subsequent implementation of an ABA parent training plan, this could certainly influence the likelihood as to whether parents will adhere to the plan in everyday life and potentially even support the positive child outcomes as well. And that's really what it's really all about, isn't it? All right. So, other pieces to consider. In summary, overall, dissatisfaction and disengagement with parent training plans can be a barrier to effective treatment for children with autism. And there are a number of different environmental factors that can influence parent perception of social meaningfulness and parent adherence to the plans. Further, the degree to which the clinician is able to collaborate and demonstrate those compassionate care skills on areas that are related to goals and selection of treatment procedures, meaningful outcomes, and then your subsequent ability to integrate all that information into the plan ahead of time may directly influence the child's outcomes in a positive way. So I'm going to end with some recommendations based on some of the emerging literature and also based on clinical experience that may help support you within your everyday clinical practices. So one thing that is super important to consider is that we have to plan beyond teaching the evidence-based strategies to parents. Yes, that's important, but there is more to the story when it comes to the likelihood of whether parents and really other caregivers and family members are going to implement the plans that you've suggested and even demonstrated to be effective in clinical environments. And more so, it's important to build those therapeutic alliances prior to working on those evidence-based teaching procedures. Demonstrate the compassionate care skills, not only throughout treatment, but also at the onset of treatment, by really engaging in some of those behaviors that we defined as compassionate care. Okay, we also want to think about, prior to the selection of those strategies, to really work with families to establish meaningful and achievable treatment goals. So what matters to the families. And also super important is to help families understand the procedures before getting started. So really explaining what is to be expected. And as you're explaining it, also ensure that those procedures are acceptable to the family. If they're not, perhaps further explanations are necessary, or perhaps consideration of selection of other procedures may also be appropriate. Also, it's important for clinicians to work with families to identify potential barriers to implementation ahead of time. Where are we going to hit those tough spots? Let's problem solve beforehand and figure out what we're going to do if those things come up. Planning for how to deal with them. And also, sometimes those barriers will be outside of the scope of our practice as behavior analysts. And so if that is the case, then we should plan for parent support across different disciplines, include other agencies where necessary, depending on the nature of the barriers that are identified. And finally, I didn't touch on this too much in my talk today, but I always like to remind us as clinicians that when we are teaching, when we get down to now teaching those specific strategies after we've developed that beautiful rapport and wonderful collaboration, just keep in mind that simply giving the family instructions on what to do and how to do it, that's not going to be enough. Instead, we know from an abundance of literature that more likely something like behavioral skills training, where we explain, model, opportunities for rehearsal, and then provide feedback, that is more likely to be effective when it comes to helping families learn those strategies. So overall, I hope you consider these recommendations and work with your families, whether it's in person, face-to-face, or through technology that allows for virtual services, to really develop that therapeutic alliance, those professional relationships in a compassionate manner, because certainly what the literature is beginning to suggest in other healthcare professions, and there's work being done right now even within the field of ABA to explore this, that not only will it help support the family, but it could potentially ultimately help support the child as well. And it's really a win-win for everyone when we're all engaged in a meaningful and compassionate way. And thank you so much for listening to our talk today. And if there are any questions, we will stick around to answer any other further questions that you have.